Our next presentation is, and the last for this oral presentation session, is by Sandra Harlass. Sandra is a senior public health officer with UNHCR with more than 20 years experience in humanitarian work. Before UNHCR, she worked with Malteser International and MSF, and her work focuses on access to quality health services in emergency and post-emergency settings. Today, she will talk to us about improvement of care for mothers and newborns in West Africa. Thank you, Sandra, and this stage is yours.
Thank you very much for the opportunity to be here. I'm happy to present today on a number of colleagues whom I listed here across 3 different countries. The project that I want to present today to save maternal and newborn lives was implemented in 3 countries, in Cameroon, Chad, and Niger, all of which are characterized by being resource-poor settings and having prolonged refugee displacement. There are ongoing insecurities in all the countries, and we see, in addition to a long-term refugee crisis, also new refugees coming in, as well as refugees moving across countries, and of course host communities moving across the country due to ongoing insecurities. We had a 3 years funding from the Bill and Melinda Gates Foundation for this project on maternal and newborn healthcare, which built up on an ongoing primary healthcare intervention across the countries, and it targeted 720,000 refugees plus the host communities around in 32 health facilities, including 8 district hospitals. At the onset of the project, we had a mixed method needs assessment looking at health facility capacities, staff capacities, attitudes and skills, but of course also at community level, community perceptions on maternal and newborn health and their priorities. And started from that then to develop tailored action plans for each of the country, but also for facility levels, and developed a detailed monitoring tool in addition to the HIS that we are using, the data of which I'm presenting here today. We then used a master trainer approach. We trained overall 91 people across the 3 years program over a number of different training courses. Focusing on helping babies and mothers survive, family planning, respect for maternity care, but also more other clinical topics like infection prevention and treatment, and also mentoring techniques on how to pass on best knowledge. From there on, the trainers were returned back to their duty stations. They were trainers from Ministry of Health and partner organizations, and implemented low-dose, high-frequency trainings in their respective facilities. So short, targeted session for staff that are repeated over time, rather than ongoing larger training curriculums. We also introduced kangaroo mother care, which wasn't used in any of the facilities before, and did minor rehabilitations to the infrastructure with a main focus on installing 24/7 electricity by solarization and improving waste management, improving equipment and supplies needed for the implementation of maternal and newborn care. And to facilitate the ongoing training, all the facilities were also equipped with a training package like mannequins, the baby natalies and others, so that the nurses and other health staff could actually practice what they are doing. At community level, we trained existing community health workers and former traditional birth attendants by adapting the WHO curriculum, caring for the newborns at home, to the national context in line with Ministry of Health guidelines, and focus there on essential newborn care, hygiene, danger signs, behavior change communication, but also preparedness for birth, how to make emergency preparedness plans, referrals, and others. The trainees were then also equipped with IEC materials, flip charts, but also weight scales to be able to measure newborns, and then conducted structured home visits throughout the pregnancy as part of their routine activities, and then followed up with a structured home visit for the first week of life for the newborns, with at least 3 visits to assess the newborn and the mother, and also make referrals then. In terms of outcomes, we had more than 33,000 deliveries supported throughout the program, and saw notable improvements in clinical skills and availabilities of essential medicines and supplies through a strengthened supply chain. Kangaroo mother care, which was not used before, was used for nearly 100% of all the neonates that had a birth weight of less than 2,000 grams, which was the main focus group for this intervention. The key thing that we saw was a significant reduction in neonatal mortality rates from initially 19 deaths per 1,000 live births down to 12 per 1,000 live births in the end of the intervention. The other thing that we looked at to really see how also clinical skills improved was the case fertility rate over time, and we looked at all newborns that were admitted with complications in the health centers and hospitals, and saw a reduction there in the overall neonatal case fatality rate of almost 50%. And then when we looked specifically at the most vulnerable, those with a low birth weight below 2,000 grams, we saw a reduction of initially from more than 30% down to 12% in the last quarter of the intervention. What we concluded from that was that the combination that we used of having this low dose, high frequency trainings, strengthening health facilities, including supply chains, and working closely with the communities to improve neonatal health did work. We saw this decrease in mortality rates and decrease in case fatality rates. We also looked at the sustainability of the intervention. We had in the funding, there was 2 project cycle fundings with a gap in between of a bit more than 6 months. And we saw that, for example, the low dose, high frequency trainings continued in 2 out of the 3 countries. The 3rd country, a lot of the trainers moved away. So we used the last project period to make some adaptation, including training additional colleagues from the regional health bureaus, their trainings that are colleagues that are coming from the area themselves, but there was a higher likelihood that they would stay on and continue the interventions beyond. We saw also sustainability in terms of supply chains and others that were implemented. What we would want to do is collect also more data to see the longer term effect after the end of the intervention. The primary healthcare project is still ongoing, but there is no additional funding at the moment for these specific activities I described. And what we could not demonstrate due to the small population sample covered was the impact on maternal mortality. We measured that as well, but there was no notable difference. Thank you very much.
Thank you, Sandra. Once again, a really good presentation, and again, very different, very relevant, and huge numbers. I'm looking for questions. No questions have appeared so far. I'm not surprised. There's so much information coming in at the same time that it's not easy to really pick the questions that you have. So one thing that was clearly shown in your presentation was that the approach needs to be multifaceted, and that training plays an absolutely important role. And you mentioned some of the tools that you used. Is there a place where everyone could have access to the toolbox, to the trainings that you used? You said low intensity, high intensity trainings, so that would be really interesting.
Yeah, we have those for our colleagues in the intranet, but happy to share that. If anybody wants to message me, then happy to share that as well bilaterally.
Perfect, thank you. Here's a question. What happened regarding follow-up after the early postnatal period, for example, from 4 weeks onwards? Was there a follow-up by other community services, for example, to monitor growth?
Yeah, so the community health workers were existing before and continued their work, and that was part of the ongoing activities. So they continued basically with their routine activities, including, like, for example, the continuous promotion of breastfeeding, the continuous promotion of immunization, especially follow up on any defaulters, but also advice on general nutrition and later on the transition. Yeah, so that's part of an ongoing activity where we just basically strengthen this specific component around birth to reduce neonatal deaths. But then we have these standard intervention that focus on hygiene and other activities as well, identifying any other danger signs of children for other diseases. So that's part of an ongoing program.
Perfect, thank you. One last question. Why did mortality increase in Q3 of 2020 after having reduced in 2019? That's a very detailed that I didn't even pick up, but yeah, that's a question from the audience.
Thank you. I was hoping that someone would ask that because I was short of time. We had, due to the insecurities in the area, refugees moved, facilities moved as well, and some facilities closed. And we, at that time, included new facilities into the program. So that, like in the beginning, where we had to really work on the quality of care, led in parts to this increase in mortality, which came down at the end again. So it wasn't the same 32 facilities that we had over time. It was this gap that we had in the care, which led to an increase and then came down again. Thanks for asking that question.
Great. Thank you very much. We move on now to our next